I would request Mr. Mohan Raj, who with an illustrious career of about 35 years in the government, presently working as the Executive Director of the Karnataka State Health System Resource Center, to take us across his presentation. Mr. Mohan Raj, you have about 10 minutes time.
Respected Chairperson, co-panelists and ladies and gentlemen, I will stick to the time schedule. I think Chairperson has been very particular about that. So, without much introduction, I would like to say from my experience over the last 30-35 years, whenever we do review at the state level or the district level, we commonly find that the infant death reports and maternal death reporting is highly underreported. There is no connection whatsoever between the IMR reported by the districts, the MMR reported by the districts, and the MMR and IMR which are published by SRS. Even our most backward districts come out with the IMR figure of 18, 20, 15, which is nowhere related to the SRS figure of 38 per 1000 labours, which is presently holds good for Karnataka. So in that background, we thought that let us do a pilot of the infant and maternal death reporting in one of the talukas, and we chose Dodballapura taluka for this because Dodballapura is a taluka which is nearer to Bangalore, because when you do a pilot, you will have to keep moving there frequently, and it is a good mixture of both urban and rural. So with that background, we took Dodballapura taluk. Our objectives was to conduct a situation analysis of what is going on as far as infant death reporting and maternal death reporting is concerned, find out the reasons for underreporting, and come out with some suggestions for correcting these maladies. So the methodology and the tools that we employed were, first we did a disk analysis of the maternal deaths and infant deaths reported by Dodballapura taluk for 2010-11. Then we had a survey done in the entire taluka using Ashas in rural areas and Anganwadi workers in urban areas. The Ashas and Anganwadi workers were trained in data collection using a very, very simple tool, which I will elaborate a little later. And when we collected the data, we focused our attention only on certain events related to like deliveries, labours, stillbirths, and infant and maternal deaths. Only these were covered. So then what we did was, we compared the statistics obtained from the survey to the figures which are reported by the Taluka Health Officer, and as a third party proof, we collected statistics from the survey from the Economics and Statistics Department. So we had 3 sets of data for comparison. So using this, we identified the areas from where these deaths were highly underreported, and we also made an attempt to come out with why this underreporting happened, and also based on that, we came out with a few recommendations. So this was a simple survey format which is used, which deals with the house. Every house was surveyed, and only those houses where the mother delivered in the previous year, from 2010 to 2011, was inquired into, and the data was collected about how the mother was after delivery. Was there an infant death or maternal death? Was there any stillbirth? So these were the data which are collected during that time using this simple format. The findings were very astonishing. We had 3 sets of data. The Taluk Health Officer reported 4,508 deliveries, 8 deliveries during 2010-11, whereas by house-to-house survey, we got a figure of 3,112. And Department of Economic Statistics didn't provide us the data about the number of deliveries. When it came to stillbirths, the Taluka report was 19 and survey report was 16, not much of difference. But again, when we came to live births, the Taluka report was 4,489, whereas the survey figure gave us something like 3,099. And the figure which was furnished by Department of Economic and Statistics for that particular year was 3,011. So you can note there is close proximity between the survey statistics and the Department of Economics and Statistics. And as far as infant death reports is concerned, it was 32 by the Taluka Health Report. That was, among the 40 deaths reported, I think 8 were pertaining to 2009-10. And since I told you earlier, we were focusing only on 2010-11, we left out 8 of them and we came out with a figure of 32, whereas by survey we got 45. And maternal deaths, there was not much difference. They were the same. So, why there is, I think we'll have to contemplate on why there were high reporting of deliveries and live births by the taluka. So, considering that, we came out that we could find out there was duplication in the same event. The birth which took place in one hospital was reported from the periphery, from the PSC and from the taluka hospital. So, the birth was single, but the reporting was duplicated, so that it figured at two places. And in 2010-11, the state had a mixture of area reporting and facility reporting. If I can tell you, I think in 2010-11, the Karnataka state resorted to facility reporting, depending on, because the government of India insisted that every state should resort to facility reporting. Earlier to that, we were doing only area reporting. So 2010-11, there was a mixture of area reporting and facility reporting. April to July was area reporting, and August to March was facility reporting. So this was another reason why there was duplicate. There was so much of divarication between the statistics furnished. And ANC registrations were also getting duplicated, because supposing a woman goes for registration of pregnancy at one place, she will be registered there. Again, when she goes to some other, say CSC or taluka at her next visit, that will also get registered there. So the same event was again getting duplicated. And also the area reporting was persisting in spite of instructions of the department. The area report was still persisting in some pockets of the taluk. So these are the reasons why there was divarication between the report furnished by the taluka health officer and what we found out by survey. So these are the, this is the finding that we had. The infant deaths that we got by survey was 32, was 45, and what reported by taluka was 32. So line listing, we compared the line listing of these two, what we got by the survey and what we got by the taluka health officer. We could find that only 15 were common to both the lists. We had two lists, one by the taluka health officer and one by house to house survey, and we found out that only 15 deaths were common to both. So apart from this 15 common, 17 extra were reported by the taluka health officer and 30 were extra reported by the survey. So in such instances where we have two sets of data, then we, in population statistics, we use that Chandrasekhar-Deming estimator, which gives the principle that when two sets of data are available, there is every possibility that both the sets could have missed some data, and that missed data, which is that data which has been missed by both survey and taluka health officer, is calculated by using the Chandrasekhar-Deming estimator. So that came out to 34. So 34 deaths were missed out by both the taluka health officer and also by the survey. So the final tally of the infant deaths which occurred in the Dodballapura taluk during 2010-11 was 15 plus 7, 15 plus 17 plus 30 plus 34. That is 96 infant deaths. So that was the realist number of deaths which should have been reported by the taluka. So this explained why there was underreporting of the infant deaths. The taluka, I told you about the low reporting of infant deaths. Taluka had adopted facility-based reporting, like the number of deliveries, and there were missed out deaths. 3 of the deaths were missed out by General Hospital Dodballapur, where deaths occurred, but they were not reported, and 1 primary health center missed out 1 infant death. And also we found that private hospital report was not at all collected, because as per the NSSO 2006, we come to know that 60% of the inpatients are treated in private hospitals and 40% are treated in government hospitals.
You'll have to hurry up, Mr. Mohan Raj.
Yes, sir. And ANMs are not collecting, 1 minute, sir. ANMs are not collecting private reports, and there was duplication of deliveries and labours and underreporting and infant deaths. So when you have duplication in labours and underreporting and infant deaths, definitely your IMR gets skewed. So ANC registrations and deliveries were getting duplicated because we are not line listing them, but whereas infant and maternal deaths are line listed. So that is why there was such a divarication. And now with the introduction and full scaling up of the MCTS, this is going to be overcome. So maternal deaths, there was not much difference. So depending on that, we came out to certain recommendations, like saying that every district should match its figures with the figures given by the registrar of births and deaths. The registrar of births and deaths in revenue areas is Tahsildar, and in the urban areas it is the municipal bodies. So we told the districts to compare their statistics with the statistics of the registrar of births and deaths and encourage prompt reporting from the department. That is, now I think during the last 1 year, the incentive for reporting the infant deaths has been increased from 100 to 500 rupees, and conduct stillbirth audit, because most of the infant deaths in some of the districts get reported as stillbirths, and also collect the statistics from the private facilities using whatever powers are vested with the district committee under Karnataka Private Medical Establishment Act, which bestows a lot of powers on the committee. So using those powers which are available with the committee, we told that periodic meetings should be conducted under the chairmanship of the Deputy Commissioner, and all facilities, private facilities, should be made to report. So these are the suggestions given. Thank you.
Thank you, Mr. Mohan Raj.